Maria and I are both transplant physicians with a special interest in Fanconi anemia. And I'm going to start by asking Maria to introduce herself and tell us 3 interesting things about herself.
Oh, that's tough. So my name is Maria Cancio. I work at Memorial Sloan-Kettering in New York City. And Stella asked me to think about 3 things that are interesting about me. And it really took me a long time. So I'm going to say these 3. The first is the accent you hear is because Spanish is my first language. The second interesting thing is that I met my husband at a cancer research hospital, a pediatric cancer research hospital. And the third thing, which is very embarrassing and I haven't shared with many people, is that I cannot ride a bike. And I have tried many times. How about yourself, Stella? What are 3 interesting things?
All right, you said you'd get your own back. So my first one, I'm also a foreigner. I'm from Liverpool in England, and I went to the same high school as John Lennon.
Oh.
Yep, and my cousin wrote the screenplay for the movie A Hard Day's Night. Wow. And he got nominated for an Oscar, and he didn't win, because if you've ever seen the movie, there is no story. They sing a bit, they run around, they sing a bit, and they run around. My second thing is I am an expert in roller derby. My daughter is one of the Cincinnati roller girls, and I am the doctor at roller girl bouts. And let me tell you, the blood and the fur flies. So that's a lot of fun. And my third thing is, talking about fur, I have little friends. I raise ragdoll cats. And this is my Charlie.
So cute, Charlie.
So there you go. So that's my 3 things to let you know. So Maria and I have been talking about what we want to talk about, and one of the things that occurred to us were the different stages of life for somebody with Fanconi anemia. And I'm just going to share a couple of slides. And Alexander, you're going to have to help me if this takes a dive. Here we go. Here's my first slide, and you can see that I like everything, little furry people of all kinds. But I love this picture because it makes me think of the stages we all go through our lives, and the stages we go through our lives with our children. And we go from puppy to elementary school, to middle school, to high school, to adulthood. And there are a lot of very standard milestones that everybody looks for. The first day at kindergarten, the first day at middle school, graduating high school, going to the prom, things like that. There are stages of life. All those things happen in families with Fanconi anemia, but there are other stages of things that people go through. And this is a little bit of a different version of how life goes. And this is kind of generalized, but this is the sort of average sequence of things. So most typically, not always, but most typically, the children are diagnosed between the age of 1 and 5 years. So on my top line is a timeline and what's happening. A little below is how we feel. And I'm sure everybody who's listening to this remembers the day they heard this diagnosis, and the terror, the befuddlement, the puzzlement, how do I deal with this, how do I handle this, that's associated with that first diagnosis. And then over time, this sort of timeline kind of evolves. And I think for a lot of people, the elementary school years are spent waiting and wondering, when is the bone marrow transplant going to be? And that's SpongeBob, waiting and worrying. And it's a really scary time of always waiting for the next shoe to drop. And I think most people on this call probably know that not everybody will get a bone marrow transplant. So waiting and wondering is sometimes harder than the actual doing. And I've had a couple of families say to me over the years, I'll say, it's time for a bone marrow transplant. And they say, thank goodness, I can stop waiting. Now I know when it's going to be. That was a surprising that was a surprising thing to me the first time I heard it, but when I thought about it, oh yeah, I kind of get that. As the children enter the teen years, we may or may not have had a bone marrow transplant, but that's when we start to worry about cancers at other sites in the head and neck or the gynecological cancers. And that's when we're starting screening visits with the doctor. And, you know, with teenagers, we do really well with screening because mum and dad make sure they come. You know, they're a captive audience, really. And so the compliance is very good, and we have a good eye on everything that's going on. As the kids reach 19 years and older and enter adult life, there's a little less marching to the appointments, and we see a little fall off with compliance, and other things happen. I put there adulting, but you know, if our kids become independent, they get jobs, they form relationships, they may get married, all of those things. And our screening and our follow-up may not be quite what we want. And similarly, there may not be insurance coverage, and I think Maggie talked about this a little bit, may not be as easy to get the kind of care at an adult facility that one is accustomed to in a pediatric facility, or to have the insurance coverage that the parents do. So these are some of the sort of things that we can talk about today and think about. But before we do that, I did want to bring, you know, one of the most important things in this adult age group, and one of the things that's becoming as big a worry as the worrying time before transplant, is this emergence of cancer in older people. And FARF has been very focused on what to do to help our community with dealing with this. And I just wanted to mention one thing that's got going this year that I think has been particularly excellent and very exciting to me as a physician, which is the Head and Neck Cancer Tumor Board. And I'm not sure if everybody's familiar with what a tumor board is, but it's a common meeting. It's usually an in-person meeting in cancer centers, and it's done for all kinds of cancer, where doctors will get together and you'll have oncologists, maybe hematologists, geneticists, pathologists, radiologists, all get together and discuss individual cases and make treatment recommendations for them. This has been very hard for many of our adult patients to get a group of doctors together, head and neck specialists, oncologists accustomed to chemotherapies or treatments that are tolerable in FA and not others. Led by Sudhir, FARF has organized a virtual head and neck tumor board where doctors from all around the country can submit their data, and a group of experts can look at it and make treatment recommendations. So I just wanted to ask Suze, if you're there, Suze, can you just tell us how people would access that if they wanted to?
Stella, hello.
Hey,
I have to be honest, I was discussing something with ISIS. Were you talking about the oral screening project?
No, ma'am. We're talking, how do people access the head and neck tumor board if they want to?
Oh, okay. Well, they can do it a number of ways. They can contact me directly through my email, suzanne@fanconi.org. They can also contact Sudhir Borgana, who is our translational science director and heads up the virtual tumor board. And his email address is simply his first name, Sudhir, S-U-D-H-I-R, @fanconi.org. Or you can always call us at the office. We're not in the office on a regular basis anymore, but we retrieve voicemails on a daily basis, a few times a day. So there's lots of ways to get a hold of us. So once you get a hold of us, if you know that you're going to have a procedure happening, then we will talk about getting you onboarded to another platform that we've partnered with called Citizen, where we can get all of your medical records uploaded into one platform so that it'll be easy for the virtual tumor board to review certain records, certain images, and then discuss the case.
And Suze, you're going to help us with questions, right?
I am.
Okay.
Are you ready for questions?
We are.
We are.
You are. Okay. So our first question is from Jen. Her 14-year-old daughter is 10 years post-transplant, and she's been having some abnormal pulmonary function tests at about 60 to 70%, but she has no obvious clinical symptoms. So she's wondering, does she assume that she does have compromised lung function, and what follow-up does she need?
So I have a big thing for this. Is that okay, Maria?
Yes.
I'll go for this. So we've spent a lot of time talking about something that we call TFL, and that's tiny Fanconi lungs. So a lot of people with Fanconi anemia have a smaller chest than the average person, and that's not factored in when you get regular lung function tests. So there's a way of looking at them differently that takes into account that your size is smaller than the average person. And we used to worry about this a ton and think, oh my goodness, there's all these people with awful lungs. But once you work this out, they're actually just fine. They're just appropriate for your size. So I think that's an important conversation to have with the pulmonologist, or if the questioner wants to send the pulmonary function tests to me, I can have my guy have a look at them. But if you're not symptomatic, you may well be just fine, I think. So it is worth getting it checked out.
I would add to that it could be something temporary versus something long-term related to the transplant. So it depends what type of conditioning the patient received. If they had radiation to the thorax, then that may have impacted the lung function, or whether they have something right now like a viral infection, even if they're not symptomatic, that may be contributing to some of the reductions in the pulmonary function tests. So also important to consult with your friendly pulmonologist at the center where you're being treated for Fanconi anemia, and they can guide as to what exactly in the pulmonary function test is down. Sometimes if it's the FEV1, which is like forced expiratory vital capacity, it may be that a trial of inhaled albuterol, for example, or any other beta-2 agonist can help and reverse some of those processes. In other cases, we're talking about diffusion of the lungs, which may be related to transplant factors.
Okay, thank you. Our next question is regarding the neurological symptoms that we've been hearing a lot about. And so we would like to have an update on just what you've learned about it.
Right, so just to fill in some background, we have seen an onset of some what appear to be new kinds of symptoms of neurological dysfunction in adults with FA. So occasionally the onset is in the teen years, but this is mostly affecting people in their 20s. And the people have developed some weakness in their arms or legs, occasional seizures, things of that kind. When this is looked at with an MRI, there's a very characteristic appearance. It looks different from anything else. And an abnormal head MRI is very common in FA. There's lots of structural abnormalities of the pituitary gland, things of that kind. This is different from that. It's in the brain tissue itself, and it tends to move around. So every time you look at an MRI, some will be gone and some will appear. This is still a work in progress, but what we have learned so far is that we think this is likely a viral infection, and it's an unusual virus called JC virus. And this can cause a lot of alarm because the MRI appearances can look like a big fat brain tumor, and it's not. So this does respond to treatment with steroids that will make it go down, but it doesn't make it go away because this is a virus that sort of lives in your body for a long time. And we're still working on it and studying it and trying to learn more, but that's what we know right now.
Okay, thank you. Our next question is from an anonymous attendee wondering about early menopause in post-transplant patients. what's the average age of this happening? And do you have any updates regarding this?
Do you want to go, Maria?
Yeah, I'll give it a go, and then you tell us what you do, what you have experience in Cincinnati. So early menopause can be related to the Fanconi anemia itself, or it can be related to the transplant. Usually we have very close endocrine monitoring after transplant, and we follow some pituitary hormones. And in cases where we do prove that the patient has early menopause, then we treat with hormonal supplements to ease some of the symptoms, such as hot flashes.
I agree with Maria.
Sorry, it's a bit of a challenge to organize these questions. So I'm doing my best just with ISIS, to get these organized in a fashion where maybe we get multiple ones answered at one time. So thank you for bearing with me. And we have another question regarding the lung issue from Noah Chairman from Israel. And she's just asking, are the lung issues common in FA?
I would say no, actually. And I do want to stress that I think if these are interpreted by somebody who's not, if lung function tests, the blowing tests, pulmonary function tests are interpreted by people who are not taking into account that children with FA may be of a slightly different shape and bulk than regular people, they will be read as abnormal when actually they are fine. So that's the first thing always to think about is, you know, have they adjusted this for the size of the individual? Because a lot of the normal ranges offered are for people of a regular height and size that age. So I think that the answer to that is, the straight question is no, it's not that common.
Agree.
Okay. And the next question is also from an anonymous attendee. When can you stop worrying about GVHD post-transplant? Can you give a time frame?
Maria?
Yes. So we're always thinking about GVHD. Acute GVHD can happen pretty much any time early in the course of transplant. So while the patient is still hospitalized for the treatment. And then after a certain period of time, you can have overlap between acute and chronic. The dogma used to be day 100, just to have something as a frame of reference in terms of timing. And after that, it's said to be that you can develop chronic GVHD. So we're always thinking about it, is the simple answer. We monitor very closely skin. Can have GVHD of the skin. That's part of the routine medical exam. Patients can also have GVHD of the liver. The liver function tests are also routinely done at every transplant center and or hematology centers. And GVHD of the gut is another thing that we monitor. And you may have seen that your doctor is always asking you very intrusive questions about your bowel habits. And that's one of the reasons why we ask those questions. Then a little bit after transplant, we'll be asking about dry eyes, dry mouth, changes in the skin, changes in your joints in terms of like how much mobility you have. So we're always thinking about it.
Okay, thank you. From, I believe, Jaco and Bonita, they're asking about their 6-year-old son who is almost 2 years post-transplant and struggles with itchy and dry skin on his face and head due to skin GVHD. He gets red flare-ups in the face almost weekly, and they're wondering if there's any advice on the long-term treatment for this.
So often topical creams can work for this. The standard ones are steroid creams, which aren't great for your face. And one thing that we do use that's a little different and is very effective but costs a lot of money is vitamin D cream. It sounds a little odd, but it's quite anti-inflammatory. It's not toxic. You can raise your vitamin D level a little bit with it. We kind of need that. But if your insurance covers it, it works great. If your insurance doesn't cover it, it's very expensive. I would stay away from it. You could use either a mild steroid or cream or something like pimecrolimus, a anti-GVH drug that's in a cream. But if the vitamin D cream can be really effective, and there is, if it's scalp, there is a vitamin D hair wash thing, a lotion that you can wash your hair with, and it's fantastic. It takes away dandruff and flakiness, which can be very common in graft versus host disease. I'm all about the hair, Sue. It's all about the hair.
Great hair.
And it looks good.
Thank you. I was just fishing for that.
You always look good. Okay, our next question is from an adult female, Louise Daglish from the UK. Hello, Louise.
Hello, Louise.
She is going to challenge me with a very long word, so bear with me. She's 19 and she's 7 years post-transplant, and she has hypogammaglobulinemia.
Very good.
She's wondering, does this make her more susceptible to certain cancers or anything else that she should be concerned about?
Can I answer, Maria, because she's British? Yeah. So that the accent will be coming handy. So Louise, so hypogammaglobulinemia means a low level of antibodies in your blood. And the number is only important if you are getting frequent infections, respiratory infections, bronchitis, ear infections, things like that. Some people with low levels of antibodies don't have any particular problems at all. However, immunoglobulins can be replaced IV on a regular basis if you are having problems. Again, it's expensive and inconvenient. So I wouldn't do it just to treat a number, but if you're having infections or problems, then it can help. And some people benefit from it in the winter and not so much in the summer when there are fewer viruses around. I do not think it will make you more susceptible to cancer.
Agree.
That's good to hear. Maria, were you going to speak to that, or should I go on to the next question?
No, I agree 100%. So see, if you're getting sick with recurrent viral infections, you may need IVIG, like for IV gamma globulin replacement. For younger children, if there's anyone who has kids with that problem, it can also be coordinated where you can give it subcutaneously, so like right under the skin. And no, as far as I know, it does not increase your risk of cancer.
Okay, thank you. Before I get to the next question, I just wanted to say that we're getting quite a few questions on screening for solid tumors, and we'd like to table those questions until the cancer discussion that we'll be having tomorrow, I believe. So just hold tight, we will get to those, but in a different session. So the next question is from Marissa and Adam Becker. They have a son who's 3 years post-transplant, and his liver functions are very high, but he has no adverse symptoms. So they're thinking that maybe this is common, and they're wondering if anybody is tracking the long-term impact of this on the liver and its overall health in FA individuals. And they say hello to Dr. Cancio.
Oh, hi, how are you? So then I'll take that question. We do see sometimes patients with Fanconi anemia who have chronically elevated AST and ALT, and we do the whole workup, checking for viruses, examining very carefully all the medications that the patient is on. And there are times that we cannot find a reason why these enzymes are elevated and then they go down and go up again. But the main thing always is to make sure the patient is not taking anything, any medications that would be associated with an increase in liver function tests, even if it's herbal remedies or other supplements. Stella, do you have anything to add?
No, I agree. This is common, and it's usually hard to find a cause for it. Occasionally, though, a liver biopsy is indicated if there might be concern that this could be GVH, but it sounds like it's a little late for that for this little person. But yes, it is frequent.
Yeah. The other thing I would add is, of course, to make sure it's not iron overload, especially in patients who were receive many transfusions before their transplant or during their transplant. So we can check in the blood ferritin, or if we have any suspicion, we can do an MRI of the liver to quantify if there's any iron deposition there.
Okay, thank you. Our next question is from Sam. They have a daughter that is 5 years old and pre-transplant, but they, I'm not quite sure, they queried baseline MRI after attending the symposium last year. So I guess they looked into or were led to believe that they should get a baseline MRI after attending the symposium. But their doctor feels that that's not necessary. So they're wondering what your opinion is on.
We generally will do one, just to establish a baseline, even in the absence of any symptoms. So typically we would.
Okay, and the next one is along the same lines about the JC virus. They'd like to know how, this is Jenny, like to know how it's acquired and is it prevalent in transplanted FA patients?
JC virus is prevalent in everybody. It's one of those things we all pick up. The frequency of people being infected with it is greater than 90%, 90. So virtually everybody has it. So Sue's probably has it, Stella probably has it, Maria probably has it. And the reason it doesn't cause any problem in us is that our cells aren't Fanconi cells, and we have nice strong T cells that are keeping it down. So JC virus only hurts people if their T cells go away. So occasionally in people not with FA, after transplant, it will act up and cause brain inflammation. And we can fix that by putting T cells back in. In FA, the problem is probably that FA cells can't keep a lid on the virus even when you've got good T cells. So the majority of people we have seen with JC virus have had a transplant, but that's probably because they are older. They are 20, 22. It has occurred in people who have not had a transplant. So it's not a transplant thing. It's not acquired during transplant. We all get it when we're probably 1 or 2 years old.
Okay. Noah is wondering if there's going to be discussion about follow-up needed, I'm assuming after transplant, and when, kind of intervals and what needs to be done.
So for people with FA, they need to be seen for the regular screenings for the head and neck and for gynecological cancer. So that becomes the most important part of the screening in the post-transplant and the adolescent and adult years. But as Maria mentioned earlier, everybody should see an endocrinologist once a year. And if people are having issues with things like, as was mentioned earlier, the early menopause, things of that kind, this is when it's very valuable to have been hooked in with an endocrinologist who will pick these things up early and be able to deal with it. So frequent follow-up, but the timing is driven by the head and neck and gynecological cancers once you get a couple of years out from transplant.
Okay, our next question about the cream that you mentioned. Would you mind, I think it was for the GVHD, I'm guessing, the name of it, and if you know that if it's expensive or not.
It's a vitamin D cream, which sounds like it should be cheap, right? But actually it's not, it's very expensive. So we get it covered by insurance, but if your insurance doesn't cover it, it really is expensive. Hundreds of dollars for a tube. So you want to check with your insurance before you go anywhere with that.
Okay, and we have a question from Marcos about his 13-year-old daughter, wanting to know if it would be risky to freeze eggs because of the hormones that might be needed for the procedure.
Do you want to go there, Maria, or shall I?
I can give it a try.
Okay.
So we do have, as part of our pre-transplant workup, we have consultation with a reproductive endocrinologist. So in some cases, families opt and patients opt to preserve their eggs so they can do family planning after the transplant. And if the patient has the luxury of time to wait for the transplant, this can be safely coordinated. In some cases, we have to move to transplant pretty quickly in cases of high-risk MDS, for example, or patients who have developed leukemia, and we don't have the time to coordinate the menstrual cycles, the hormones, etc. So I would say if it's safe and you have time, definitely something to talk about with your Fanconi physician and the reproductive endocrinologist.
So we fairly rarely store eggs, but we will freeze ovary. We will offer ovarian freezing to anybody who wants to do it, and you can do that down to infancy, because you don't need to offer stimulation with hormones. You're not producing eggs. You take a wedge of the ovary and you store it. And we do it at the time that the children are getting a central line placed for transplant usually, so there's no additional anesthesia. But it's important to understand that this is a research procedure. This is not what you see when you read about IVF. The thing with stimulating eggs is that the girls have to be relatively sexually mature. You have to have gone through most of puberty to be able to produce the eggs, and it is time consuming and kind of awkward. Of course, the major downsides of the frozen ovary is that we have relatively little experience with it. There have been successful pregnancies by going this route, but I'm talking about less than 50. So it is a kind of experimental thing, but age probably doesn't matter. We offer it at any age, knowing that it may be 20 or 30 years before that child may want to go back to that product. And that's quick and easy because there's no hormones involved.
Yes, and I should have said that sometimes our patients actually opt for freezing as well. And we also try to coordinate during the same anesthesia that we're using for central line placement pre-transplant.
Okay, thank you. This might be one of our last questions, but it's also in the gynecological vein. From a 23-year-old female with FA wondering when she should start having pap smears due to the higher increased risk of gynecological cancers. I think she's heard that maybe it's 25 in the general population, and should she have it sooner?
Absolutely, yes. Yesterday.
Mm-hmm.
Yesterday.
So do you have an age that you recommend?
So we start gynecological visits when the girls are about 10. And it's just an external examination at that time. There's no internal, it's to get the girls used to being looked at. And then they will proceed as, depending on how mature the girls are, as the children get older, they will have a more extensive examination. But right away, absolutely right away.
And I would encourage you to make sure your gynecologist knows that you have Fanconi anemia, and what that means. It's a rare disorder. To us, we live and breathe Fanconi anemia, but some physicians that are very competent have never heard of FA or have heard about it, but don't know that the risk of solid tumors can be up to 500 times as high as the general population. So definitely worth mentioning and reminding your physician about that.
Okay, and we actually have time for a couple more short questions. So they're both around liver function. The first one is an alkaline phosphatase level around 500. I'm a little confused on the question. I'm thinking, should it be checked? How often should it be checked? I think is the question.
Maria, what do you think?
Well, the alphas level has to be looked at by age. There are different ranges. So I'm not sure 500, and depending on the lab, that doesn't sound incredibly high. Definitely the trend is what I would worry the most about. If it's something that is up once, then your physician can decide when they can follow again. If there's something that is continuously going up, of course, needs to be taken more seriously.
Okay, and the next question has also given me a challenge with terms, so bear with me.
You're doing well, Liz, you're doing well.
So they're wondering, this is an anonymous person, have you encountered post-transplant FA patients with non-alcoholic steatohepatitis or NASH, also accompanied with high liver functions of 15 plus post-transplant?
So steatohepatitis is inflammation of the liver due to the storage of fat in the liver. This is an interesting question because I think we're all familiar with people with Fanconi anemia being too thin, but not everybody is. And about 20% of people are not as small as some of the others. And if you get a lot of fat deposited in the liver, and that might be because you're generally a bigger person, or sometimes it's due to metabolic abnormalities, it will cause inflammation of the liver. And often weight loss can be helpful, but if one isn't heavy to begin with, it would be important to look at the rest of the metabolism. And we have seen it before. It can happen, but it is something probably a good idea to try and address as well as possible.
Okay, thank you. That's the end of our questions for now, but we have one comment that says, Stella, your hair looks really good, but we've seen your shoes.
No shoes today, no shoes.
Okay, so I think Jordan's going to take it over into our next session, and just remember that you can ask the questions over on Slack. And thank you both for being here so much.